everyone, and welcome to HTQ's second session of our autumn seminar series on data. Before we begin today, I'd like to acknowledge the traditional owners of the lands on which I stand, the Turrbal and the Ugra peoples, and to all traditional owners of country across Australia. I pay my respect to their ancestors and descendants who continue cultural and spiritual connections to country. I recognise their valuable contributions to Australian and global society and acknowledge that these have always been places of teaching, learning, research, and collaboration. For today's session on data management and analytics for healthcare, I am thrilled to welcome our hosts, Rudolf Schnetler from Townsville Institute of Health Research and Innovation, and Sankalp Khanna from the CSIRO. Before I hand you over, I'd just like to remind you that we have one more session coming up on 16th April on Indigenous data sovereignty and health research, and you can register for that event on the HTQ website. So I'll hand you over now to Rudolf to start off today's presentation.
Good morning, everyone, and thank you, Helen, for the introduction. I'm just going to go through a quick agenda for this morning. So we've got 4 topics. I'll be running the first 2 with data management planning in the early stages of research and the importance of documentation, especially around reproducibility and sharing. I'll be handing over to Sankalp after my presentation to talk about analytics and artificial intelligence and applying scientific rigor and planning to execute data science projects. All right, so the first 2 topics, I really want to expand on the first session's work and the amazing session we had last regarding data governance that really touched on the planning. For today, I'm going to steer away from governance. We've already discussed that, but I do want to give some information today, especially for research projects for early career or people, researchers going through their first research project, and where to start that and how to start that, and give some guidance and tooling that really help you go through and build a rigorous data management plan for your research project. The second topic I want to discuss today is the importance of documentation, especially around data reproducibility. We know that's a difficult area to navigate in health research with data ethics or human research ethics, data governance, and other laws and policies and procedures we have to follow in agencies that manage health data. But it's still quite a bit where we can do here to be able to share what we've done in a safe and secure manner to the wider research community. Okay, so kicking off, data management planning. My team, so I lead the research data laboratory within the Townsville University Hospital, and we assist researchers with data management planning every day. The biggest tool that I can hand over today and help researchers guide their planning is the data lifecycle model. So we'll be going through that. I know that was briefly covered in the last session. We're going to expand on that a little bit today, but really focus on what topics we need to focus on for your HTQ proposal, so your human research ethics proposal, and how to just expand with that in the protocol before going to your governance approval and before kicking off your project. So it's really early stages and what we need to think about as we're writing that protocol. As I mentioned, we can really look at the protocol in the area today. Again, I'm going to exclude data governance for today. I refer you to the first session. It's on YouTube. Absolutely amazing work over there. Okay, so the data lifecycle. As we can see, there's multiple areas we can look at, from planning through design, enabling, all the way through to enhancing. For today, I really want to focus on the plan. What we're going to do with that plan is we're going to touch on each of those subsequent elements and how we can explain that in our data management plan in our protocol, and what specific items we need to call out within our human research ethics documentation and submission. So what I would recommend, and I do see this a lot, it seems obvious calling this out, but I do see researchers starting on their human research ethics application or their university ethics application, whatever that might look like if you're using mice models or different things. But there's your ethics application, and then there's your actual study protocol. What I would highly recommend everyone do is take your protocol as the source of truth for your work moving forward. The protocol is used for your HTQ application, again, as the source of truth for what you're actually executing. It's also used for your source of truth for your governance and then subsequent data release. If you start at the protocol and you flesh out your data management plan there, you can simply keep reiterating that plan across different stages of your approvals. When you start your protocol, again, what we find is a lot of researchers, which makes sense, focus on their hypothesis, the research questions, and methodology. I would recommend that also to add the data management plan at that very early stage. The reason for that is that depending on your research question and what you're trying to achieve, you really need to start thinking early about how to obtain, store, dispose, and enhance your data. Depending on your protocol and what you're proposing to do, those stages might be quite in depth, and you need to start engaging with your organization early to meet those requirements. I've already mentioned this, your data management plan will be considered cross. What I have found some researchers do is actually have the protocol and then refer to the data management plan as an appendix. You can do that as well. At Townsville Hospital, we do both. We either incorporate the data management plan within the single document, in the single protocol, or you have a separate document that just outlines the management plan. Again, it really depends on how large your project is, but call it out as a separate section in a single protocol or have as an appendix. Use the life cycle I showed before to guide you on each step. I'll reiterate the big areas for us to look at is how you're going to obtain or create data, meaning you're going to have a survey that collects data from users, from consumers, how you're going to store that data and what safety security protocols you have to in place to store that data, how that data will be disposed of, and how we can enhance that data, meaning how can we make sure that data is reusable or reproducible, which we'll talk about in the second topic today. A key item I would recommend to start, so a starting guide, is the data management section in the National Statement for Ethical Conduct and Human Research. So our national statement outlines, obviously, a lot of information for researchers depending on what you're doing, and has, broad requirements for data management. Section 3.143 to 3.149, which I'll be going through in a second, has some very specific key pointed questions that will really guide your starting point for your data management plan. And here they are. So through these points, the critical items that I would recommend in section 3 is for your project team, have an agreement within the project team with your PI and your AIs on who's the data custodian. Is it simply the PI, or is it the project, or is that custodianship handed off? Remembering that you as the project team are the ones collecting and using and deriving new information from that data. You become the custodian of that data, and also the intellectual property of that data. That's step one, is agree who's going to control that data and who's the custodian. That's really, really important, especially for further and future use. So you might have another project, or another project comes to you, say, hey, you've done all this amazing work, you've done all this fantastic collection, how can we use that to help us with this question? Then the custodian can potentially give access to the data with the appropriate approvals. Per that data lifecycle that we showed before, the HTQ also considers and calls out specifically how the data is collected, accessed, used, disseminated, and disposed. In my opinion, what I see a lot of protocols come through at the laboratory, collected, accessed, and used, and disposed is heavily explained and well explained. Disseminated is where there's usually a bit of a misunderstanding. When you write your protocol, really focus on these areas, on how it's collected. Are you going to have a survey, or is your data being handed to you by a third party? How was that data being collected? who has access within your team and future access, and how's access being authorized and managed. How are you using the data? That's usually explained in your statistical analysis. Disseminated. Please explain clearly to the HTREC and in your protocol the difference between the data you're collecting and using and what you're presenting in the future. A key concrete example would be that for the most part of all papers I've seen, we don't present identifiable information within the journal paper. We usually present demographic, statistical sampling and showing what our demographics look like or whatever results we generated. But at an individual level, we keep that to ourselves for privacy. Explain that. Explain what you're collecting, what that looks like versus what you're presenting. Aggregated, anonymized data in journals only versus we're managing and using identifiable data potentially within the project. Is that just that difference and how that data is anonymized is really, really important. The next steps is your information security agreements. I would recommend engaging your organization early. For universities, there's more than enough resources on how data can be stored, the security that's in place for that storage. For us at the hospital, we also provide wide-ranging information security information to our researchers on how we can securely store information to meet privacy. Make sure that you comply with all legal regulatory requirements, especially around privacy. Again, I'm not going to touch this too much. That's mainly data governance, but explain what controls you have in place to meet your governance requirements. Engage your governance office early to better understand those obligations. Preservation of biological samples, how you're going to keep your samples, who's keeping them, where they're being kept, all information disposal and how they're being disposed. Per the national statement, depending on your cohort, there's different requirements. So for adults, there's a requirement. For children's another requirement. And depending on how your study is designed, the committee might put further requirements on there. It's just explaining, okay, to meet those requirements, we're going to dispose it this way with whatever audit controls are required as well. And the data should be reusable. How can it be reused and in an ethical manner should be explained. All right, so the second bit I want to talk about is documentation. It tails off that last statement of reusability. So as you saw before, we put a lot of effort into making sure our data is safe, secure. We've collected through potentially hundreds of consumers. You've put a lot of resource into this. This data is an asset that you're using to derive new information and insights to. It'd be an absolute waste to just put that into archive. Depending on the data source or the data you've collected, that might be the most ethical manner due to safety, security, privacy to make sure that data is heavily secured. But there's also a lot that we can do to potentially anonymize that data or change that data or even just produce metadata. So data about the data, explaining what we've collected, how we've collected it, so that the wider community can understand, oh, okay, this group has done this body of research, they've collected this asset, this data collection. We understand what's in there. Maybe we can write a proposal and get ethical approval to reuse that data for future research for whatever question they might have. And that will then be agreement between, whatever organization, the data custodian, but at least you're then providing that transparency of what's being collected and how it can be used. I have seen a lot of data just be archived, which I believe can drive a lot further research in the future. Understanding though, and I'm trying to frame this, I understand, and someone who works in data releases and who's responsible for data releases within my organization, the data sharing can be extremely difficult to navigate. It can be quite nerve-wracking when you get your data ethics approval, your governance, and you have a full assessment that has been given to you for your data release. You want to make sure you're doing the right thing. What I'm going to suggest today is what tooling you can use to present what methods you will use to ensure that you keep privacy, ensure that your work is still ethical, but enabling sharing and reusability as well. So that's my goal for today. And I'm gonna show how we can enable that in a constrained environment. For example, again, I work within the health service, so privacy is number one for us, making sure our consumer data isn't released without the proper controls in place. What I would like to present today for especially early researchers or researchers who's currently writing their proposal is the FAIR principles. And I'm sure a lot of people have seen the FAIR principles before. What I'm going to do today is just go through the FAIR principles and then how we can use that for reproducibility specifically. And I'm also going to show a tool that you can use today to assess your FAIR, how fair your data is. So the FAIR principles was developed in 2016, and the key drivers for this work and this framework was to support knowledge and innovation through data integration and promoting sharing and reuse of data. The key principle was to ensure that we can ensure that data is findable, so the data has sufficient metadata or unique identifiers to easily be discovered by other researchers. Now, for people in this seminar today, the most common one we use and what everyone might be used to is data dictionaries. So at the laboratory, when we do a data release, we actually provide our customers with a data dictionary as well as the data release, just simply explaining the column, what's inside that column, or what's expected to be inside that column or feature. For example, comorbidity, what the type is, how it's identified, the range potentially, depending on what that variable might be, and any identifiers or outliers and how we removed or managed outliers. That's just very simple starting point. That is metadata. That's data about your data, and that is de-identified. There's no identifiers or personal information in that. You can publish that. You can say, we collected our data and it's structured this way. That's a great starting point. Might not be sufficient with all the metrics within FAIR, but it's a very strong starting point to make your data findable, going, yep, this is what we've done, and you can find our metadata here. Institutions hosts metadata repositories, and we will at the hospital, at the Townsville Hospital, we'll be hosting one as well for researchers in the near future. It talks about accessibility, how easy to access your data. Now, this one can be quite difficult for us in health research. What I would recommend here is that you can state that, okay, the raw identifiable, highly sensitive information isn't accessible. However, we have done the following work to de-identify our data and can be accessed here, here, and here, or in these methods. I'd highly recommend looking at the data.gov.au or the same portal, but for Queensland. They have a whole methodology and even metrics on how you can publish your data, open data format, which we're working towards as well internally within Queensland Health. Interoperability, so once you've done all that work, how are you sharing that data? What format? I would recommend, and this is something that I don't see often, is how did you save that data? So, okay, there's nothing wrong with saving it as a CSV, but giving, again, metadata on how it's saved, how the data is separated, and potential caveats or shortfalls, meaning how we manage certain data types. That really, really assists with interoperability. And then lastly, reusability. In the FAIR principles framework, reusability, they talk about more usage license. So how can people use your data? How easily can they use their data without breaking any licensing agreements? And the provenance, so how the data was extracted and then transformed. Work with your local technical team. We at the hospital, at the laboratory, we provide researchers with source information and how we transform our data as well upon request. So for the FAIR principles for reproducibility, I would talk about identifiers. So how to identify your data. I would highly recommend uploading your data set to a repository and get a international identifier for your data. So you can put that in your publications. You can publish that and say, yep, this is where our data sits. One such repository can also be data.gov.au. and they give you an ID to report your data set. Describe your data with metadata. So I went through that in a bit of detail before. That's, I believe, the biggest thing that researchers can do is create strong and well-detailed information about your data. Either then the community can reach out to you directly to see if they can get access, or they can build reproducible pipelines to recreate that data in their own environment. Lastly, have a look at how your metadata records being kept. So upload that to a metadata repository, have an ID for that, and ensure that your the retention, what is the retention, how long is being kept, what data format that metadata is in, and can that metadata be linked to other areas. Now, if you're wondering, okay, how do I assess these things? How do I know where I'm up to with my work? What I would like to present today is just the fair assessment tool. So the ARDC has created this amazing tool that's basically a survey that goes through each of those features. It goes through findable, it goes through each questionnaire item, and you can explore that questionnaire early and start answering those questions yourself and seeing where you're up to and where you need to improve your current metadata descriptions, how it's being stored, how easy is it to find. You can add from that feedback, you can then make changes to your proposal to ensure that you're meeting those requirements. I'm not saying chase for 100%. Sometimes you can't, especially on privacy concerns, but it gives you a very strong indication of where your data sits. It gives you a score and it shows you where you can improve. This tool will really help you just better understand where to improve your reproducibility, and you can then put that into your proposal before it goes for ethical and governance review. Thank you. That's my time. I'm going to hand it over to my colleague Sankalp. Thank you very much.
Thanks, Rudy. So I'm going to talk about using analytics and AI, but I'll really start with the why, share a little flavor of the type of research we're doing, introduce some of the problems we tend to face, and then try and bring that all together with an example of a project we worked on and the barriers we faced and how we overcome them. So really just a conversation starter. I'm happy to discuss more about any of these things if you like. So the why is the easy bit to explain, especially to an audience like this. The Australian health system, as you see on the left, this is a comparison with OECD countries, does fairly well. You kind of want to be on the right side of the average, which is the orange dot, and the green is where Australia sits. And as you can see, other than the fact that we probably eat and drink more than the rest of the world, we're doing pretty well in terms of health outcomes and in terms of available health resources. This is the comparison to OECD countries pre-COVID. But if you look on the right side, and here's the problem, our health spending, and this is pre-COVID, has grown at an unsustainable rate, well past what our population growth has been, making the system pretty much unsustainable. And you hear a lot about how we're going to run out of money for health expenses. Also, these pictures you see here are not our countries and other parts of the world. These are Australian hospitals, and these are patients waiting to be seen in Australian hospitals. So that's really the motivation of why we need to do more, why we need analytics, why we need that data-driven thing. And this slide is from a report that CSIRO did for the government a few years ago around the need. If you're going to try and do more with less, the need is to have a data-driven approach to try and use the data that's being collected in the health system and to change healthcare to trying to improve consumer health and well-being, trying to move more towards precision health, unlocking that value of that digitized data. And really, that's where digital solutions come into that picture. At the Australian eHealth Research Centre, which is a joint venture between CSIRO and Queensland Health, and that's how we started, and we've now grown to a national centre. The research is broadly across 3 areas. We do a lot of work in the health services space where we look at service delivery models that look at telehealth, mobile health, your virtual care, remote monitoring, those kind of services, primarily aimed at chronic disease. We have a big team working in biomedical informatics, doing a lot of the biostats and imaging and genomics-based workflows, and health informatics, where I sit. Teams looking at trying to improve health system productivity, trying to improve the underlying data interoperability to try and build solutions for clinical and operational decision making. The work that my team does is broadly across 3 areas. We do a lot of work in trying to inform evidence-driven healthcare, trying to build tools around that health system productivity, and around more recently as data is available in real time through the EMR, trying to inform clinical decision support. The image on the right tries to convey the idea that one size fits all solutions don't work in healthcare, and you need multiple solutions looking at the entire life cycle of healthcare if you're going to try and make a change. In each of those 3 areas, a little flavor of the type of work you're doing. In that evidence-based healthcare, we're doing a lot of work in hospital access and patient flow. We are one of the largest published groups in the country in this space. Most of that collaborative work has stemmed or started with Queensland Health. And at the moment, we are involved in a large study with Queensland Health, Queensland Ambulance Service, UQ collaborators to try and inform and look for evidence-driven public health emergency department solutions. So watch this space probably mid of this year for a final report in that space. But a lot of that work has focused on trying to understand the bottlenecks and look at evidence-driven strategies for improving flow. We've done a lot of work in the clinical insights and reporting, and I think a good example of that more recently has been our involvement in the International COVID Critical Care Consortium, which involved data from 63 countries across 6 continents. So there was a massive collection of data from nearly 450 hospitals and care centers across the world. And this is a Queensland-driven effort. We've also been contributing statistical expertise to various collaborators, university partners, health partners, and partners that are working on different types of sort of statistical or clinical insight type solutions to try and progress what's available to making sure that whatever we're doing, care delivery is evidence-driven. On the operational decision support side of things, the approach has been to try and build solutions that transform the health management to being proactive instead of reactive. So predictive tools to try and inform who's going to come to hospital so that you're not trying to react to an overcrowded hospital on Monday afternoon, trying to get a better understanding, a better feel of that, trying to use that data-driven approach instead of this is how we've always done it, so this is how we continue doing it. Making sure that if you've got these really expert health administrators looking at screens, trying to inform decision making, if they are out of their offices attending an HTQ seminar, whoever's looking at the screen is still making the same decision, given that it's data driven, it's not left on the knowledge in somebody's brain. What type of stuff do we use? We use time series forecasting models, machine learning models, a lot of simulation, optimization, mathematical models, and more recently moving into digital twins. And we're building a digital twin of the Queensland patch, the patient flow control room, alongside healthcare improvement unit. What you see on the right there is a solution we built for Austin Health in Victoria around trying to get a better understanding of when to book a patient in next when they come in for the outpatient appointment, because doctors generally book them in without realizing that they may not be able to see the patient in that time frame they want. Other than that, we're doing a lot of work around trying to optimize outpatient and surgery workflows, trying to do surveillance, syndromic surveillance, and trying to do different types of scenario-based decision making. On the clinical decision support side of things, the focus here has moved to trying to build precision decision support solutions to provide predictions to clinicians that they can trust, that they can use. And so it's not just about giving them a prediction saying this patient is likely to have a risk of cardiac arrest or is likely to have a readmission or is likely to contract sepsis, but it's about trying to provide an explanation behind why that model is saying that this patient is going to have that problem. So trying to provide a prediction and a risk profile which highlights what factors are going to be behind that, and also trying to build solutions that meet the regulatory requirements of software as a medical device, because that legislation has now come in. And if we're going to build these solutions and try and roll them out, we need to be able to meet the requirements of the TGA in terms of self-certifying the algorithms that we use. What you see on the right is two different examples, one of a risk algorithm developed in Queensland. We did a trial where we demonstrated how that could connect with Cerner automatically and provide risk support. And this was done with Alcidian at Murrumbidgee. And at the bottom, you see an algorithm that we developed for the Australian Government Healthcare Homes trial that is now embedded within a commercial population health management solution for primary care. What are we trying to predict? We are trying to predict preventable hospitalizations in primary care and acute care, clinical deterioration among adults, neonatal adverse outcomes, including sepsis with Westmead, different types of other adverse outcomes, including the risk of a central line infection, the risk of fatal liver disease related complications, post-operative hypotension, and other things. What is the problem? What do we face now? When you go to university, you study this, a typical software project lifecycle or an analytics project lifecycle, and you understand that, okay, there's this cyclic process where you do the discovery, you get your ethics and all of those things, and you get your data, build your model, share the findings with your collaborators, tweak it a little bit, and then deploy it. That's great. In healthcare, it's a little bit more complex because once we get the data, we start planning the model, we find, oh crap, need to go back and get something new because you discovered a problem. And so you need to go back and restart that process. And Rudy kind of gave you a flavor of how complex that can be, but often we need to go back and request something additional that we had not realized we needed. We then go back, incorporate that, and go back to the model planning, then start the analytics, and then we kind of realize, we need to go back and either get some more data, or we need to go back and reconsider something we had not considered. And you can see where I'm going with this, right? So, and at every stage, we find ourselves going back. At every stage, we need to kind of consider some new information, consider some complexity in the data, think about, oh, when we looked at this, there were these factors that we did not consider, and now we need to go back and either incorporate some new process, or we need to go back and get some new data elements to build this. And the other issue that we tend to face is there's a lot of with the data collections, we have barriers such as data quality issues, and you see the three sort of examples on the right where that date of birth, it's hard to talk about whether that's the 2nd of December or the 12th of Feb, and these are all real examples from projects we've done. The weight there is actually for an adult and is actually not in kilos, it's in stone, which it took us time to realize. On a prescription, when we're getting an extract from something like the ELMS pharmacy database, we find that the medicine names got the name of the pharmacy. And it's only after trying to understand the process, you realize that it's this is the only way clinicians can actually put or guide a patient into where to go, because they want to print the name of the pharmacy on the prescription. So they found a hack. They put the name of the pharmacy in the medicine name for an elderly patient or a patient visiting from overseas, because that's the only thing that actually gets printed. But that hack makes the analytics part difficult, because we then have to find the data and cure all of these problems out of it. Beyond that, there's that issue around structural interoperability, where you've got different hospitals collecting data in different ways. You've got the issue of semantic interoperability, where different hospitals or different departments or even different doctors will collect data a little differently, will have slightly different workflows, and then trying to build models that can actually be scaled become challenging. As a result, we spend about 80% of our time in trying to get the data ready. We build models which are for specific use cases. And then that results in very poor transferability or scalability, because we built this model with one hospital to get a really good model that suits them. And now we want to roll it out to statewide use, and we realize, okay, it doesn't work. And we're using a certain medications database here, which the other hospitals are not using, or their processes are a bit different. And the workflow aspects we considered don't exist. So there's a bunch of these sort of problems which make it difficult. And really something to consider here is if you're trying to build analytic solutions, we need to be trying to move from the bespoke models we are currently building to what you see on the bottom right, the general models. And if you don't do that, you can't build solutions that can actually be scaled and be used across, sometimes even an entire hospital. You build a model with a certain department and you want to try and use it more broadly within that that hospital, or within that hospital and health service, or across the state. And that development's a bit hard, because it's easier actually to build a model for a specific facility. It's even relatively cheaper. But if you try to build a model that's reusable and scalable, which is the target, it often lands up being more complex, more expensive, and sometimes even less accurate. Also very important to consider is, from these points of view, is what metrics you use for performance testing. Because as you sort of try to scale these things, or you try to build something, you realize that, okay, maybe I'm not using the right metric, or I'm not considering all dimensions of performance that I need to be looking at. To put all of this in context, I'll spend the next 5 odd minutes talking about some work we've been doing in Queensland Health, trying to build predictive algorithms to inform in-hospital care to reduce patient readmission. We started doing this work back in 2010-11 with the Logan Borders at Health Coalition, and that flowchart you see on the right was the first thing that was shared with us around saying, you know what, we've got this model where we've got these community hospital interface program. We've got these nurses that walk around and look at patients that are admitted in wards and try to identify patients that would benefit from some sort of intervention when they're leaving hospital, or some better discharge planning around informing their GPs or any other type of community care services to manage them better when they're out of hospital. So that blue arrow represents where they said, can you introduce a machine learning algorithm here to help us better understand who these patients are, instead of relying on the nurse's intuition to pick these people up. And we went away saying, oh, that sounds reasonable. We can do this. There were some similar algorithms introduced in UK. So we started with the focus being chronic disease. We chose a fairly broad definition of chronic disease, what you see on the right there, by ICD-10 codes. And we got data from Logan and Borders at hospitals, and we ran our initial models. What did we realize? That when you're looking at the patient visits, or each patient's visits over a 5 or 10 year period, you realize that there are gaps. And getting data from just those 2 hospitals did not cover their entire stays in Queensland hospitals. So we went back and expanded the ethics and requested data for other surrounding hospitals. And we reassessed that data, and we found that, okay, there were more patients going to Gold Coast Hospital from Logan than they were coming to PA in some cases. And so we then had to expand to get data from all Queensland hospitals for these patients, even though our focus was Logan and Port Desert. And there was multiple sort of changes to the ethics. We also found that when we built our first models, the models did really, really well. We were able to predict with up to 95% accuracy, and I'll say accuracy here for a minute, who's going to come back to hospital. And we went very excited and shared those findings with clinicians at Logan and said, you know what, every Tuesday and Thursday, these patients are going to come back for dialysis. And they said, yeah, we know that, we booked them in. Machine learning at the end of it is pattern recognition. And when you feed it and look for all-cause readmission, and most papers out there, scientific papers, try to predict all-cause readmission, it identifies the patients that are routine patients that are coming in for things like rehab, that are coming in for dialysis and all of those things. We also realized that the metric that we were looking at was wrong. And accuracy is a popular metric that is used for predictive models. For something like readmission and for a lot of health outcomes, it's the wrong metric. Because if your readmission rate is about between 5 and 10%, let's say 10%, if your model was nobody's coming back, you're right 90% of the time. And that led us to thinking, okay, we need to get a better understanding of what we are measuring. We want to take away the cases that the clinicians are not interested in, even if that brings the model performance down. And we don't want to use accuracy as a metric. So we used a mix of other metrics, including area under a receiver operator characteristic curve, which is a balance between the sensitivity and specificity of a model. And we removed the dialysis admissions. And we saw, okay, we can still get reasonably decent performance. Then clinicians said, can you focus only on the emergency admissions? We are not interested in the planned ones. We also looked at that stage, Queensland for a short period had a 28-day readmission target. So we looked at that versus a 30-day target. And we also looked at, do we consider readmissions or emergency readmissions or representation? And each time we tried to extend this, we had to go back and modify our ethics and get permission to look at something a little bit different. So we then build these models using data for chronic disease patients over 5 years, which are Logan Board as patients, but had visited any Queensland hospital for anything in that period. We removed some of the routine admissions or pregnancy-related obstetric admissions. We removed the index admissions, which is the first admission in each instance, because we wanted to predict from the second admission. So we've got some historic data to use for the prediction. And we removed patient deaths, because a patient dying and not coming back because they've died after being discharged from hospital is not a good outcome, it's a bad outcome. And we looked at readmissions within 30 days or through the ED, and all of the factors clinicians wanted to look at. We used varied sort of statistical and machine learning approaches, and we came up with models that had robust performance using the right metrics. So we had good statistical rigor involved in all of this, and we developed these algorithms. And then Queensland Health said, so what? You've built these models, but do they actually improve the process? Do they actually help the staff? If they do, how do they help the staff? How should we target this? And there was no evidence out there looking at this. So we got funding to do a trial in hospital to say, okay, let's look at all the chronic disease patients admitted to hospital. So any patient who's bum in bed, let's generate a risk score for them overnight and provide it to the care teams looking after them so they can use it for care planning or discharge planning. We started the trial, and Logan decided to shift to the IEMR. And so they deployed that, and they were having a change of system, and it was very complex to do it during that. So we then extended the trial for another 12 months once the IEMR transition was done. We collected a lot of those findings, and we shared them back with Queensland Health. One of the things that really helped here was how we were presenting the results. So we looked at, and this originally the plan was not to use a decision support tool. The original plan was just to share the predictions. But in that consultation and co-development with the clinicians, we realized that, okay, we did not want to give them a risk score saying 40% or 60% risk. We wanted to put it in sort of adjusted to the population, because the risk profile of patients at Logan Hospital would be very different from, say, somewhere like Wesley Hospital. So we wanted to put that in risk profile. We wanted to give them filters so that nurses who were looking at specific cohorts, looking only at people from a non-English speaking background or diabetic patients or whatever, could filter down to their cohort of choice. And we also wanted to give them some kind of understanding when they clicked on a patient's risk on what was contributing to that risk. And you see over here, a patient who's actually younger, but has had multiple stays in the hospital and ED visits and has some abnormal pathology, and how each of those is contributing to that risk, as opposed to what is a more typical profile for readmitting patients who are older, have had come back to the hospital multiple times because of cardiac issues, and have had fewer emergent visits. So you could look at these patients differently and understand what type of intervention to introduce for them. We also got some very interesting insights from the trial, where we realized that the clinicians were not entrusted. We thought these top 5%, this is the biggest finding we'll have, and we're really going to make a difference for these patients. But the nurses knew these patients. The nurses knew these patients back of the hand. They knew their wives' names too, because these were coming back all the time. And they then it was that emerging risk, the top 10 and top 20% risk, that was really new patients for them. And that's where they got the most value from the algorithm in identifying these patients that were emerging risk before they become frequent flyers and were already in the system. And so there were findings like that that were very useful, that as data scientists we didn't think about. And then we shared that back. We were then asked to build models for statewide use. And we delivered this actually during the COVID period, and we are exploring how this should be rolled out in collaboration with Queensland Health, how this can be rolled out across the states. The only point I'll mention about these was one model was not good enough for all of Queensland, so we built 3 different sets of models. We built one model for the Children's Hospital, because that data was very different to the other hospitals. One model for the principal referral or the largest hospitals, and then a third model for all the other public acute hospitals. And between those 3 models, we were able to capture the different risk profiles for patients. That's my summary slide. And the idea here is, what do you need to be thinking about when you're building these models? How do you get your value from doing work in that health analytics space? Rudy talked about the governance aspects and making sure you have the right ethical and regulatory stuff, that you've taken that into account. My key message to you would be co-design, getting the stakeholders involved early on, and valuing the data, and making sure you're you're trying to understand the pain points and how that model is going to be used, and then building your machine learning models to address that, and not the other way around, which often happens. But I'll kind of stop there and ask if people have some questions.
Thank you, Sankalp. I've answered a few of the questions around the data management piece. There's just 3 there currently around your work, which is really exciting. If you either
Sure.
want to catch those live, yeah.
Sure. The first question, and I'll just try to answer them live. Mark, your question around, do they end up classified as software medical devices? And do you do clinical trials to prove them before going live? Yes, the operational algorithms, such as when we are trying to predict who's going to come to hospital, or we are trying to do stuff around trying to inform clinic management and stuff, do not get classified as medical devices, but the risk algorithms do. And depending on what you're using it for, whether you're trying to predict readmission or you're trying to predict deterioration or sepsis, the classification might change. And there's a requirement. So we are in the process. We spent a lot of time on this over the last 2 years. We are not experts in this space, though. We are in the process of getting certified. We're setting up our own quality management system that meets the TG, that meets the international compliance requirements, so that a lot of work we're doing with the imaging and the clinical decision support algorithms can be certified. We're also working with industry partners on how, because CSIRO can never be a manufacturer of these algorithms. So some of that manufacturer responsibility will sit with the organization that adopts our algorithms. And so we are also working on that space. I hope that sort of answers your question a little bit. The second question from Christine, do you need to have participant consent to store de-identified data? Might be a little bit of yours and a little bit of mine. In our case, we seek waiver of consent because we are sort of routinely collected data that's already in the hospital system. And a lot of these patients are often untraceable, or they've passed away. And so we seek a waiver of consent, which we are allowed to. There are some studies where we collect data when we are doing, say, a clinical trial in hospital. For those, we need to seek participant consent. When we did a trial of the risk algorithms, we had to get participant consent from all of the clinicians and nurses that were actually entering the surveys or attending the focus groups. So sometimes yes, sometimes no. And Swapna, you have a question about the methodology used, which can provide these features. So, okay, this is a really important question. I think the methodology needs to consider how that algorithm is going to get used. And with due respect to a lot of other research that's happening out there, I often find that that aspect of statistical rigor is never considered enough. We built a model for trying to predict um, um, patient risk of hospitalization in the primary care setting. And at that stage, unlike the model I just introduced, the model I just introduced predicts patient risk when a patient comes into hospital. So it's at the point when the care needs to be provided. That's when you're predicting that risk. And the methodology there was very different um, compared to when we built the models where we had to look at identifying patients in the primary care setting who might be at risk to bring them into a trial. So there we were sort of scanning the patient database for the last 2 years, 3 years to identify patients that might be at risk. And we had to consider um, isolating the last year of data. We could not use that because we had to make sure that they were alive for that period. And there was no way to connect that data to the death registry. So we had to quarantine that last year from their most recent visit because we knew if they're coming back, they were alive in that period. So your study design needs to mimic A, how you're going to use the prediction, and B, what data is available at the point of prediction. For these readmission models, when they were built in the UK, they had information about hospital visits in the primary care database. We don't have that in Australia. So it's those elements that you need to consider. Very often in readmission, I find that people consider ICD codes from the current visit. Now the coding does not happen. There's a 3 to 6 week lag in coding. So you can't, but researchers get an extract and they assume that that data is there, don't realize different information gets entered at different times. And that's again, something that needs to be considered. So I'm trying to go through this very quickly. Olia, you have a question about what type of model did you end up using? So it again changes the model that was used for what I just shared. The statewide models was an XGB model that came out as best. The model that we used for the initial risk trial at Logan Hospital was a regression-based model. And how do you getting about the model to output the contributing factors? Now, if I understand your question right, with something like regression is really simple because it's an explainable model. With tree-based models, there's partial explainability, but we then overlay something like one of the heuristic algorithms like LIME or SHAP to get an approximation. We've got a recent paper which actually talks about the fact that even that explainability is not perfect, but our feedback with clinicians we work with is it's somewhere, it's a start for them to consider. Professor Scott, do you have any outcome data on whether the readmission risk model has reduced readmissions? That was very hard to do. That was very hard to look at. I think the design we were asked to sort of incorporate looked at a comparison over the study period with, it was actually PA hospital. We looked at Logan versus PA and we said, okay, let's consider PA as a control and what reduction did they have over that period of time compared to Logan that was using this algorithm. I don't think that was a very good comparison, but as we sort of do this, we're learning from our efforts and we're trying to get better understanding and comparison. So the short answer is not a reliable yes to that. Sorry, I'm just being really, really frank on what I think. I think this is the start, and I think we all need to share and pool knowledge on how to do this, right? Nobody's got the answer to this. John, co-design and stakeholder engagement can be a challenge, especially in the complex hospital environment. Did we have to bring in extra people and skills? It's a challenge, but it's the only way to do it. And I'll say it's getting easier. If we, like I said, the first model we built, we did not take a lot of consultation into account. The first trial we designed, we did not think a lot about that, and we found gaps there. If you don't do the co-design, if you don't spend a lot of time understanding the data, you'll build a model that's not suitable for clinical practice. And I think the critical success is doing it right from the start and making sure it's problem owner-led thinking. And sometimes, with due respect, the problem owner's not got all the answers because they are not the only problem owner. When you talk to the person who's funding the study as the problem owner, you then need to go and consult even further down with other people, the other stakeholders, the nurses and the bed managers and all of these different people to collect multiple perspectives and employ all of them together in your models. and learn from that. Olia, the reference for that paper is in the slides that will be shared. It was on the last slide. For two of the papers, therefore, it'll be shared. But if you need references to other work, I'm happy to share that. The explainable machine learning for real-time deterioration alert. That was not the study I was talking about, Swapna. That's another study which was conducted with data from PA Hospital trying to predict real-time deterioration. But there's it's the statewide risk readmission models. Both of them are in the same journal, Nature Scientific Reports, around the same time. But the reference will be in this paper. But that's also a very interesting study to read and a slightly different study design.
Okay, everyone, I think we will close today's session. I want to thank Rudolf and Sankalp for a fantastic presentation, and to everybody who attended. Just a reminder that the slides and a copy of the recording will be available on the HTQ website later this week. And if you registered via Eventbrite, you will receive an email notification letting you know when those resources are available for download. And I'll just close today by reminding you that our last session in this series will run on the 16th of April. And if you haven't already done so, I would encourage you to register either via the link in the webinar chat or directly on the HTQ website. Thanks, everyone.
Thank you.